My dear colleagues, you know the COVID time has been a tough time for us. I've been conducting face workshops every year from 1994 onwards. And this year I was not able to conduct it because of this COVID situation. So there was a request from many of my colleagues, junior colleagues, and especially the fresh graduates that there were a lot of queries whether I was conducting face workshop this year. So I said, I'm not able to do it. So as per their request, I thought that I will just upload some of these lectures so that you will be able to follow this comparatively better. So this particular slide, the first lecture which I am going to give to you is on treatment planning. And there will be following few lectures will be there on the treatment and other cephalometric analysis and prediction tracing, etc. will follow later. Coming to the next slide. Before you start the treatment planning, you have to do medical evaluation, oral cavity evaluation, and psychological evaluation. Along with that, the most important is aesthetic evaluation of the patient, because orthognathic surgery means surgical straightening of the jaw. So natural aesthetic evaluation is the most important. I need not tell you anything much about the medical evaluation. And evaluation of the oral cavity, it is very definite that the oral cavity has to be really healthy before you do the surgery. When you say about psychological evaluation, what I want to tell you is that many patients may come to you with imaginary complaints, and they may be having some unrealistic expectations as well. That you have to be very careful. So don't give them much hopes about it. And of course, the patient who is really aware of the real problem they have got, they are the ones. Self-motivated patients are the best one. This psychological evaluation for that matter is important. Many people come with unrealistic expectations. You have to take them very carefully. Coming to the aesthetic evaluation, that is more important for them. That is what I am going to explain here. Aesthetic evaluation of the patient. You see, usually the line which is being taken is the Frankfurt horizontal plane. See, cephalometric analysis, we'll have another lecture later. And so I'm not going to talk about the cephalometric analysis right now. It is the clinical evaluation that is more important right now. So what I'm saying is that, face is usually an oval in shape, a normal face. So the bizygomatic width, that is this one, is almost 0.86 with the length of the face. Understand? That is one important thing. And again, bizygomatic width and the bigonial width. Bigonial width is, this is 0.70 of the bizygomatic width. And the face tapers down to the chin. That is actually comparatively, you call it a beautiful face. Okay. Now, face can be three types of face you can see here. One is a convex one, and the other one is straight. We want always a face to be straight, and this is the concave one. So straight face is probably most aesthetic. And there are three types of faces are there. One is almost square, one is oblong, and the other one is almost in the between. That is a normal face. And the arch will be, it will be V-shaped or U-shaped or something between V and U. That is one which is normally seen. And the next slide shows the proportion between the face. Usually the proportion is taken from the hairline to the chin. It can be divided into three equal parts. That is, a line is being drawn in the glabella. This area is called the glabella. From the hairline to the glabella, from the glabella to the subnasal, that was the root of the columella, and then the lower part. So this will be equally three parts. And coming here from the hairline to the glabella, and well, sometimes it's getting okay. Here the subnasal, from subnasal to the stomion. Stomion is where the two lips meet, or there is a upper lip vermillion, upper lip stomion, as well as the lower lip stomion. But when in a normal face, it will be this area. So this will be half of this lower part, that is stomion to the menton. Now coming to the certain other things that we have to take into consideration is the nasolabial angle. Nasolabial angle is 90 to 120 normally. And if it is acute, that means there is a proclusion of the upper anteriors. That is what it shows. And this is actually depends on the angulation of the columella also. This also has to be taken into consideration. So, and there are certain lines. I'll explain it a little later. And this angulation, as I said, it's 90 to 120. And this is maybe I consider this as the most important line with the treatment planning. A horizontal line, that is a clinical horizontal line, is wrong. It is almost similar to the Frankfurt horizontal plane, and clinical horizontal line is drawn, and the perpendicular is drawn to that clinical horizontal line through the subnasal. And this line is expected to go about at the through the upper lip vermilion border, and about 2 millimeters anterior to the lower lip vermilion, and about 4 millimeters anterior to the pogonium, soft tissue pogonium. This is a very, very important thing. So many of the things can be assessed from here. So if there is any discrepancy, you can see whether the maxilla is protruded or retruded, and whether the mandible is protruded or retruded, whether the chin alone or the dentoalveolar segment, etc. All these things can be found out from here. This is one of the important things. And another important thing is that this is called aesthetic line. That is, and from the tip of the nose to the tip of, to the pogonium, a line is being drawn, and this line is expected to go anterior to the lower, to the lips. The lips are not expected to either touch it or not, but it should be behind it. That is one important aesthetic evaluation. And this another line to find out whether the nose is prominent or not. A horizontal line again, I mean a vertical line again, drawn at the tip of the nose, at the subnasal, and the root of the alar base. And this should be 40 and this should be 60. That is normal. If it anything different, 60, less than 60, that means the prominence of the nose is comparatively less. And if it is more, it's a prominent nose. Another thing what you can draw is that, you know, through the nasion, that is nasion is a point where the frontal bone meets the nasal bone, and from there a perpendicular line is again drawn through the to Frankfurt horizontal plane. This line is expected to go through the point A, a little anterior to the point B, and then it touches the bony pogonium. Now, this is just to consider the possibilities and limitation of orthognathic surgery, and of course, 3 modalities of treatment. This I have taken, this is a modified picture from William and Profit, and see, the central point is where the final position of the tooth. This inner circle is the movement of orthodontically how much you can move is being shown here. Somewhere around almost up to 6 to 7 millimeters, you can retrude the teeth by orthodontically. Almost say 1 centimeter up to almost 1 to 1 centimeter. Here it is being shown as 7 millimeter. And the next circle is one by functional appliances. You will be able to move almost up to 12 millimeters. Functional appliances has to be started in a young age before the growth is being completed. No, while the growth spurt starts, you may have to start the functional appliances. And this is what we'll be able to achieve by surgery. Surgery, as you know, it is being done after the growth period is completed. That is usually after 18 years. We will be able to almost 1.5 centimeters, we'll be able to take the entire maxilla backwards by anterior axial osteotomy. And again, almost 10 millimeter, 1 centimeter, you will be able to bring forward. And this is the moment. This is the area of surgical approach. That is what we are more concerned right now. This is also one important for us because this is a distraction osteogenesis. You know that distraction, Ilisaro's technique of distraction can be applied to the maxilla, where the maxilla is about 1 millimeter every day. It can be brought forward, and the maxilla comes forward almost 25 millimeters. That is 0.25 centimeters. You will be able to bring the maxilla forward by distraction osteogenesis, that is a substantial amount of bone. And you are creating bone in between. When you cut the bone and distract it, you are creating bone in that cut. That is the biggest advantage of it. Not just simply distracting it and keeping it there. The bone forms. 1 millimeter every day, you will be able to grow the bone. And here coming to the mandible, again, this inner circle is the orthodontic movement, and just the outer circle, the middle circle is the functional appliances, and the outer circle is the surgical. Here we say that the mandible can be taken forward by something like backward by something about almost 1.5 to 2 centimeter, and advancement can be almost up to 12 millimeter, that is just 1.2 centimeter. Distraction osteogenesis mandible can be again taken by somewhere around 2.5 centimeter. It can be taken forward. This is what shows the distraction. This is a modification that I have done to the William and Profit measurements. And we talk about the possibilities. You know, I told about the Lifford 1, and I mean about the surgery and all those things we will be talking later. But Lifford 1 osteotomy is just all of you know about the Lifford 1 fracture. Maxilla is fractured almost in the same line. Here you can see from the picture where it is being fractured, and then maxilla can be taken forward and upwards. You can remove a segment of bone from here and take maxilla can be taken upwards. So this is what is usually being done for the maxillary osteotomies, and it can also be taken a little backward. It can be taken forward, and but it is not easy for the maxilla to be taken backward because the pterygoid plates are restricting the movement of the maxilla backward. That is it. Here, this is anterior maxillary osteotomy, and you extract one premolar. That is usually either first or second premolar, whatever, according to your convenience, according to the requirement. So you remove it, and segment of bone is removed from here. That is connected together the anterior segment alone, involving the canine, lateral, and central. All these things on all 6 teeth are being pushed backwards. So if there is a dento-alveolar protrusion of the maxilla alone, this is the one that has to be done. When there is a vertical excess of the maxilla, what you have to do is a Lifford 1 osteotomy. And coming to that a little later, about the mandible. Mandible can be usually there is a prognathic mandible is there, retrognathic mandible is there, chin deficiency may be there, dento-alveolar protrusion may be there, all these things may be there, and even an open bite also could be there, all these things. Now, the sagittal split osteotomy is the one, we will describe about it later. Sagittal split osteotomy is the one which is being usually done. It is a versatile procedure, that is one advantage. Mandible can be pushed backward and backward or forward in sagittal split osteotomy. So, mandible, this is the cut, and then this is called a subsigmoid vertical osteotomy. This is the mandibular foramen. You have to make the cut just behind the mandibular foramen through the sigmoid notch inferiorly to the lower border, and this posterior segment is overlapped on this, and the maxillar mandible can be pushed backward. So that is subsigmoid. But in this case, you have to do a submandibular incision. You have to put an incision below below the mandible, in the angle of the mandible extraorally, and I will tell you later about it. Here in the mandible, this is lower anterior subapical osteotomy. I said that when there is an open bite or dento-alveolar protrusion alone, then you will be able to do extraction of first premolar preferably, because when you are taking 5, you cannot take the 5 in this case, because 5 if you are taking the mental foramen is somewhere here. So it may not be very advisable to extract 5, but you have to extract 4 and then remove a segment, and this is being cut and then push backward. So you can dento-alveolar protrusion of the mandible can be corrected by this particular procedure. Here, this is a V osteotomy in this region. So when an open bite or something of the like an open bite, this is probably a better procedure that is advisable. And here, genoplasty. Genoplasty again is a versatile procedure. You can move the chin in almost all the 3 dimensions, forward, backward, and sideways as well. A minimal asymmetry of the mandible, chin, can be done by genoplasty. Treatment planning, coming to it, I will show some of the cases where, here look at these 2 young women. She has got a lip incompetence, and in the rest position, all her teeth are visible. and see that her lip is not very short. So visibility of the teeth with a normal lip, that means there is a vertical excess of the maxilla. So the maxilla is vertical excess. That is the reason why she was not able to close her lips. Here it is the gummy smile. This visibility of the teeth could be also due to very short lip, but in this case it is not a short lip. And in this case, she has got a gummy smile. Gummy smile means, she has got, when she is smiling, her gums are visible. Usually it is also because of the vertical excess of the maxilla. And there is another reason why there could be a gummy smile. That is hyperactivity of the levator muscles of the lip. That also could be one of the reasons. So that also you have to assess whether it is the lip position. That is, normally the lower border of the lip, vermilion, is expected to lie in the incisal line of the teeth. A 2 millimeter visibility is considered to be within normal limits. Now you have to okay, you are doing the bone, mainly surgery is on the bone, but you have to be concerned about the relationship of the tooth also. This is a class 1 relationship, which is supposed to be the normal one. Class 2 relationship is usually associated with the anteroposterior excess of the maxilla, and class 2 division 1 when there is a retroclination of the anteriors, and class 3 is when there is a mandibular prognathism. That is basically the thing. So that's about the occlusion part. The treatment planning, I have already mentioned about the nasolabial angle, proportions of the face, and the aesthetic lines, subnasal perpendicular, and facial asymmetry can be assessed by just vertical as well as horizontal lines, or putting the photograph in on a grid. You will be able to assess where the problem lies. I'll come to that little later. Here you can just see another girl who has got a Frankfurt horizontal plane, or rather clinical horizontal, natural head position, horizontal plane, the natural head position. This is not a natural position. She has raised her head a little up. That is the reason why we had to put a line like this. That is something goes on the tragus through the infraorbital border, is supposed to be the Frankfurt horizontal line. And perpendicular to that, through the subnasal is being drawn. Here you see, she has got a lip incompetence that suggests vertical maxillary excess. And when the upper lip is actually protruded outside this particular lines of maxillary, there is a proclination of the upper anterior teeth. There is anteroposterior excess of the maxilla, not only vertical, anteroposterior excess is also there. Look at the lip, lower lip. Lower lip should have been 2 millimeters behind, but it is again forward. That means there is a dentoalveolar protrusion. Here the chin is actually normal in position. The problem here is that she is trying to close her lips. So you can see that puckering here. So this is why the chin doesn't look in the normally. Here this should be here, this much difference between this and this is there. So now this particular patient has a vertical maxillary excess of the lower third, vertical excess, vertical excess of the lower third of the face, visibility of upper teeth, all these things I have already explained, and the convex face. Another girl, see, she has got here also again, this is the clinical Frankfurt horizontal plane, and then subnasal perpendicular. The upper lip is actually a little prominent, lower lip is also prominent, and chin is quite deficient. So what does this girl need? She needs a Lifford 1 osteotomy to correct the vertical excess of the maxilla, and an anterior maxillary osteotomy to correct the, I'm sorry about it, anterior maxillary osteotomy to push back the anterior segments. When my hand touches this one, that is what it happens. Okay, it's all right. And then she has got here dentoalveolar protrusion, which can be corrected in 2 ways. One by lower subapical osteotomy, or by orthodontic means. You can extract it 4 or 5 and then retrude, so that overjet can be increased. So there is no need of doing a lower subapical osteotomy. Here you have to see that we have to do a genoplasty for her because her chin is very deficient. So it is always advisable to do a pre-surgical orthodontics in this case, so that the dentoalveolar segment is pushed back, is retruded. So overjet will be there. You can do a Lifford 1, superior positioning the maxilla, an anterior maxillary osteotomy along with it, and push it backward. And this is what the results what we have got. And of course, a genoplasty can be done at the same time. If you are doing a lower subapical osteotomy, then it is not easy to do a genoplasty because you are cutting almost in the same region. So, but mandible may become 4 pieces, one here, and one in the dentoalveolar segment and chin. So the stability of the mandible will be lost, and you may find it very difficult to actually stabilize the mandible properly. So this is a postoperative picture of this patient. You can see that the difference. See, the chin is brought forward, labiomental sulcus has become well defined, nasolabial angle has become almost 90, and the subnasal perpendicular almost in the same position. You can see here the cephalometric analysis which has been done also. When you come to cephalometric analysis, we have got a lecture later, so I'm not going into the details of cephalometric analysis here. SNA, when it is, usually it is 82 degrees, anything more than 80 to 84 degrees, plus or minus 2 is always considered within normal limits. So anything more than 84 is considered to be maxillary excess. And here in the mandible, some maxillary deficiency she has got here. Here you can see that in a mandibular deficiency 91, it is obtuse. So I mean acute. The nasolabial angle is acute. That means there is a proclination of the upper anteriors. A proclination of the upper anteriors becomes it is a compensatory mechanism, or because when the maxilla is deficient and the mandible is prominent, there will be always a tendency to keep the lip opposed. So naturally, the pressure from the lower lip on the lower anteriors will be comparatively higher, and the lower lip will become, lower teeth will become what, retroclined, and the upper teeth, there is no resistance from the upper lip over the teeth, so it will become proclined. That is what happens in this case. That is why the nasolabial angle has become a little acute. So she has got a convex profile. Coming to this analysis, again, somewhere around SN, not SNA, this is SNA is 80, and 2 millimeter up to 80 is all right. If it is less than 78, we should consider that maxilla is deficient. When you come to the mandibular prognathism, here you can see the vertical, subsequent vertical which I have taken. Upper lip is almost in the normally, but the lower lip is much permanent. It should have been 2 millimeters behind. So almost should have gone almost 4 millimeters backward. Here also, chin should have been 4 millimeters, but here it is almost in the air. So if you take the mandible by somewhere around 4 millimeters backward, this prognathism will be corrected. Understand? So it is very clear we can plan how much the mandible has to go back from this itself. So maxilla is in the normally, and then the mandible somewhere around 4 millimeters, you have to take it backward by sagittal split osteotomy. That's it here. Cephalometric findings for maxillary excess is basically SNB. SNB should be somewhere around the angle more than 82 degree, sella, nasion, and point B. That is SNB. Point SNB should be angle more than 80 is normal for the mandible, and up to 2 millimeters we find it within normal limits. And if it is more than 82 degrees, then it is an indication of prognathic mandible. Of course, you have to consider point SNA and SNB together, and well, then only you will be able to take a proper decision whether the mandible is prognathic or retrographic. Open bite deformity is something very, very important, which you have to see. In this case, you have to do a cephalometric analysis and find out. And here, the position of the upper lip is also very important. And see, there is an open bite. It could be because so many other reasons, so many reasons could be there. It is usually because it is a tongue thrusting habit, or lip sucking, tongue thrusting, or thumb sucking habits. All this could cause an open bite. So you have to find out the open bite is basically where the open bite is, where the deformity is, whether it's in the posterior region of the maxilla or whether it's in the anterior. Curvoscopy is another technique by which you will be able to find out. You have to find out whether it is in the maxillary region or in the mandibular region. In this case, I feel that orthodontic treatment will be able to take care of the upper teeth because there is a slight protrusion of the anteriors. So orthodontic treatment and take it and bring it to the alignment of the posteriors looks normal. But here there is a slightly downward angulation of the anterior. So and a slight mandibular prognathism as well. So a subapical osteotomy with the 4-4 extraction and subapical over subapical will probably result in a good result. So coming to the facial asymmetry can be pan-facial asymmetry, or it can be there in the one area only, in the chin only. Here he has got the reasons for facial asymmetry are hemifacial microsomia, unilateral cleft lip and palate, and other unilateral clefting syndromes, childhood trauma, especially to the condyle, discrepancy of blood supply to the maxillofacial region, habits, early unilateral loss of teeth, faulty use of functional appliances, pathologies and childhood surgeries of the face, growth discrepancies. All these things can cause facial symmetry. Here, this patient this is something congenital or developmental. He is not giving any history. This should be, see, chin is not in the midline, so we should consider that there is a slight hyperactivity, hyperplasia of the mandible or the entire face, especially the mandible on the left side of the patient. Here, he has got a deficiency on the right side. His chin is slightly pushed this side. Actually, what has happened is that, he had an ankylosis of the temporomandibular joint, and this side is actually normal. That is why it is being, midline is slightly pushed this side. Here, he has got an ankylosis. So we may feel that this side is the one which is deficient. Actually not, because this side is not growing properly, and this particular side has been dragged aside. That is why you feel a sunken appearance here and a fullness here. The problem is on the right side, on the left side of the patient, this side, actually. Coming to surgery, Lifford 1 osteotomy, the Lifford 1 osteotomy is done in the line of Lifford 1 fracture, and this is the greater palatine vessels. Try not to injure that, because that is the one which gives blood supply to the maxilla. Of course, there are other vessels which is coming, especially the ascending palatine artery is also there. Even if it is being cut, there is nothing much to worry about it. You will have enough perfusion of the blood, so the blood supply will be there. But try not to injure it, because better blood supply will be there. And anterior maxillary osteotomy, premolar extraction, taking it upward to the maxillary sinus, and from there a cross cut to the nasal cavity and the opposite side, and that's connected together. Central incisor, lateral, and canine. Premolar is being extracted here, and this is basically done, as I told earlier. This is for anterior, posterior exits of the maxilla. These two things can be combined together also. Mandible, when it is there, sagittal split osteotomy, where it is sagittally starting from the medial aspect of the mandible to the buccal aspect, and almost up to the level of 6 or 7, a vertical cut is being done, and the mandible is split here, and then it is really positioned properly. Either mandible can be pushed backward or forward. If you want advancement, you can make it, and the plating is being done, whatever. And here, this is a subapical osteotomy of the lower subapical osteotomy. After extracting the premolar, you can cut this and fix it push it backward. Genoplasty, after cutting the chin, you can take it forward, backward, or sideways. This is another case with a cleft lip and cleft palate case. You can just see the nose. It is completely flattened out. That means that the entire maxilla is actually deficient. Here, we have to take the maxilla forward. You have to plan whether you have to do a Lifford 1 or a Lifford 2 osteotomy. Here, I think that we have done a Lifford 1 osteotomy. That was sufficient, because subtical nasal bone, it was perfectly all right. It is when the nose is taken. Lifford 1 osteotomy is taken. You see, in the cleft lip and cleft palate cases, when the palate is being repaired, there is a lot of scar tissue formation there in the palate, which will prevent the growth of the maxilla. That is the reason why the maxilla is deficient. It is being done at the age of 1 to 1.5 years before the child starts speaking. You have to do the cleft palate surgery. Cleft lip should be done a little even earlier. And then cicatrization will prevent the growth of the maxilla, and also it will favor relapse once you take the maxilla forward. But in this case, maxilla is being taken forward. So to prevent the relapse, you always have to go for a rigid fixation. And see, the nose has come forward, and the angulation also has come better. Now, this is a mandibular prognathism case which I have shown, which is there. So what I have done is that I did a subsigmoid vertical osteotomy here. Submandibular, extraoral submandibular incision is being done, and subsigmoid osteotomy is done, and the mandible is pushed backward. And this is the result, what is being put. It can be done by bilateral sagittal split. When you are putting a subsigmoid, extraoral incision, this region, you have to be very careful about the marginal mandibular nerve, which is a motor nerve. So that will affect the function of the lip. So care should be taken to protect the marginal mandibular nerve. Here, see the patient, if you drop a subnasal perpendicular for this patient, his upper lip, nasolabial angle is within normal limits, and the subnasal will come through the upper lip vermillion. Lower lip is also in the normal position, but chin you see very, very deficient. So you need to do only a genoplasty for this patient. A single sliding genoplasty may not be sufficient because too deficient it is. So I've done a double sliding genoplasty. That is, 2 cuts are being made, and this is being pulled forward and fixed. That is what is being done. So look at this patient. This is the front view, and this is the side view and the profile. And this is front view before and after. You can see the X-rays also here. Facial asymmetry is another thing which I have already mentioned about it. How we plan, I will tell you. Horizontal lines and vertical lines are also drawn. Horizontal lines in this case I had drawn in the infraorbital region, and between the ala and the occlusal plane and the lower border. Now you see this is actually diverging when it comes here. That means the left side of his mandible is hyperplasia of this left side. So what you had, because there is no occlusal plane, that means the maxilla. There's on the entire area, maxilla is also large here on the left side. Mandible is also large in this area, and actually eyes, because it is being closed, you cannot see, but the eyes are also, there is a slight thing is there. But for that, it is a very major procedure we have to do for such a mild difference, it is not worth doing it. So what I have done is that I did a Lefort 1 osteotomy and anti-clockwise rotated it so that the occlusal plane of the maxilla has come forward. Did a bilateral sagittal split osteotomy so that the occlusion is corrected here. So the occlusal plane has become almost normal. And then inferior border, there is a prominence here in the inferior border. There is vertical excess of the body of the mandible here also. So a segment is inferior border osteectomy was done to remove the excess of the bone. So this is a post-operative, pre-operative, post-operative, and pre-operative and post-operative pictures. Thank you, gentlemen. I think that we will be able to come out with more lectures in the future about maxillary osteotomies, mandibular osteotomies, etc. Thank you very much.